David, that's a very clean desk.
Thanks, Bill. It's deceptive because it's a conference table instead. So,
Oh, good.
Unfortunately, my desk is not this clean.
Too loud.
John Rolfe is having trouble logging in, so just hold tight a couple more minutes, please, everyone. Thank you.
Are we getting royalties or from Mountain Dew for advertisements for this call? Sometimes we make money on those. Just looking for revenue where we can find it.
I'm not sure if my drinking this is good for Mountain Dew's stock or bad for Mountain Dew's stock, Mr. Speaker, but a little caffeine gets us through the day.
Good product placement either way.
Very good. Okay. I believe John Rolfe has joined us. So good morning, everyone. I'm David Tolan, chair of the Spark Task Force. Very pleased to be able to meet this morning. I think I'm going to start by calling the roll. President Masterson?
Here.
Speaker Reichman?
Here.
Secretary Burns-Wallace?
Here. Here.
Mr. Orman? Mr. Orman? We may have just lost him. There we go. Greg, can you hear us?
Yeah, I can. I was having. But
thank you.
I think they're fixed.
Mr. Pickard?
Here.
And Mr. Rolfe?
Here.
Terrific. Thank you all for being here. Thanks to those who are joining. Are we getting some feedback?
If everyone else could, David's talking, please.
Okay, we're going to try this again. How does that sound? All right, thank you. So grateful for folks joining us today. Purpose of this meeting is to consider a specific request, and I want to note that we all agree on the importance of having a thoughtful process to guide our investment of Spark funds with clear goals and consideration of trade-offs of costs and benefits. However, we also, I think, agree that we urgently need to support our frontline nurses and healthcare workers who are serving to address this surge in the COVID-19 pandemic that we're seeing across our state. And so while we're still working on process and we need to work expeditiously on the process, we also cannot delay taking action on an immediate health and safety priority for our state. And so with that, I'd like to call on Member John Rolfe to give us an overview of a proposal. So, Mr. Rolfe?
Albeit via the internet. Oh, can you hear me now? Sorry about that. I had said so many eloquent things before you unmuted me. I'll start over. Great to see you all again. Glad we can be meeting again, and thank you, Lieutenant Governor, for handing this over. Do you want to? Is it worth pulling up the proposal, or do you want me to just talk about it more in scope, and then we can get into the details later?
Why don't you talk about it at a high level, and then we'll get into the details.
All right, perfect. So I'll be telling you all many things that you already know, but I think how we organize it does help with all of that. So we know we're in a situation again where our hospitals are at capacity. I was just checking the board through Mission Control this morning, and almost no ICU capacity except at St. Luke's out of the Tier 1 and Tier 2 hospitals. Which has been creating issues for people being able to transfer in for acute care, whether that's COVID related or not. What we're seeing, as the hospitals have described to me, is normal hospital activity for this time of year with COVID on top of it. Our last surge we had last time, and we were pretty close to on lockdown, you didn't have the normal activities going on out there, so hospital traffic was lower with a higher COVID surge on top of it. And what happens is, as you all know, is the acute care centers get backed up, and then the ability to transfer out of the rural hospitals into the hospitals with more ability to care for that acuteness, you get backed up. And whether that you're there because you need your gallbladder out or you have another routine surgery. And we saw a sad example of this in McPherson just a couple of weeks ago, where a gentleman named Rob Van Pelt had problems in a routine surgery and couldn't get to an acute center in 3 days and ended up passing away. What's happening with the hospital capacity isn't what we've dealt with before. So hospitals generally get bottlenecked in one of three ways. So there is stuff, space, and staff. Stuff would have been the issue at the beginning of the pandemic where we didn't have enough PPE equipment. So you think masks and gowns and eye protection and all that sort of stuff. The bottleneck now isn't necessarily space. This isn't a need to go set up field hospitals with more beds. There's actually bed capacity out there. We're having a staff issue, a people issue. There's several things going into this. One, there was a nursing shortage before the pandemic ever started. And then secondly, there is a burnout factor where people have been through this once. They're worried about the energy it would take to go through this a second time. And so they're either leaving the industry if they're maybe want to take an earlier retirement, or they're moving to a lower stress clinical environment. And then the third thing is, since most states that are experiencing these surges right now are short on staff, you're having traveler nurses that were the surge protection, and the rates for travelers has gone up quite a bit. We've read reports as high as $230, $250 in states like Texas and Florida for traveling nurses. And so nurses are being recruited out of their normal service in Kansas hospitals and hospitals all across the country to become travelers to go help with the surge, which helps in the surge but hurts in the current places. And hard to blame people for doing that. They can make as much in 2 months as they can in a whole year. But all that's creating an issue with a staffing crisis, which really is creating our issue with capacity in the state around hospitals. So that's the underlying assumption inside of all this. If in the case is that our capacity issues right now are related to staff issues more than any other issue that's out there right now, and that's what needs to be addressed in ways that we can. So when we started these conversations with the hospital association, some of the hospitals, there was thoughts about how you retain the people that we have now. So a very difficult environment. Everybody's trying to recruit. There's labor shortages across all industries. I can certainly testify to that inside of my industry. But how do we retain the people we have? How do we protect the capacity that we have right now? Knowing that we're coming into the busier season for hospitals in the winter. Generally, they're built for the winter capacity and the things that happen through the winter around influenza and RSV and things like that, among other health issues in the winter. Is how do we retain the staff to protect the capacity we have, and then how do we have money for travelers? Boston Consulting has come to the conclusion through their networks that there's opportunities for nonprofit hospitals to find reimbursement for traveling nurses related to COVID and some other expenses like that. And so we're going to explore that tranche. I think the Hospital Association and some nonprofit hospitals are having meetings with BCG and Wood O'Brien around those issues to try and tackle that issue this way. So that then comes when it comes to Spark and ARPA. Obviously we want to try and exhaust funds everywhere else before we have to come to this committee. Would be what can we do around retention? We started with the idea of talking about retention bonuses. Again, Boston Consulting's come back and said around ARPA, what we can do through their regulations on this is not bonus, but we can do premium pay with the guardrails of up to $13 an hour and no more than $25,000 a year. So those are the two guardrails that they put on this, and that has to come through as a premium pay. So we said, well, how do we make sure, because it's hard to pull staffing information in a reliable way. It's hard to know number of staff beds because all that stuff changes daily based on who's sick and who can be there and who's on vacation and what's going on. The most reliable number that we could find to look at the size of a hospital was the number of licensed beds. And because this is, trying to look at COVID, the situation we're in because of that, and really the situation that's created around acute care, the first stipulation was that this was targeted towards general hospitals with an emergency room or emergency department. They're generally the ones dealing with the acute care and the movement of folks with that. Licensed beds was the number we knew we could count on. Now, I think it's pretty well known that hospitals rarely are operating at their licensed bed capacity, but that is a federally known number and reported number, and generally does give you a picture of the size of the hospital and how many people they're serving and how many beds they're operating. So knowing that that was a solid number that was already available, that's what the calculation started off of. And then we go into the kind of federally recognized nursing staffing ratios. So for a med surge or inpatient bed, that's a 6-to-1 ratio is the typical ratio that one nurse looks at 6 beds, looks after 6 patients. And in the ICU, that is a 2-to-1 ratio. So every nurse is looking at after 2 beds. And so knowing what licensed beds across the state in the hospitals, this is rural, urban, everything in between, we were able to say, okay, this would be about the number of nurses they'd have based on those beds. Knowing that nurses aren't the only ones where they're short and there's a need for retention, there's a plus 20% on top of that. So and when we get in the details, we can go through this calculation because it's better to see it than just to hear it. But there's, you have to think through not only the ratios, but you have to have 3 shifts a day, and you need to be covering 7 days a week, not just 5 days a week, because people can't take the weekend off from being sick. So that was the calculation, which roughly came up to the numbers when you see it, when you take all that and targeting the number of $5,000 per person that would qualify as a baseline number, not a promise. I want to make sure that's not the idea isn't that we're going to pass this and every nurse on the front lines is going to get $5,000, but this is to create the allocation amount per hospital that they can use and have some flexibility to target towards these frontline workers that are really exerting a lot of effort and energy to help us have a reliable healthcare system in the state of Kansas. And so you take that number of workers times 5,000, and that's where the number came to 49.2 million across the state. And then I believe that number was rounded up. Certainly shouldn't take $800,000 to administer this program, but just to make sure there was space for administration, which I think would go through KDHE and then DeWitt O'Brien. So we can talk about those individual numbers and all that, but in concept, this is about protecting the capacity that we have in the state through the winter, making sure our nurses and frontline workers know that they're seen and appreciated, and to help them have one more reason that may tilt them to stay and not vacate the industry or the state, and to make sure that we're creating and protecting as much margin as we can in the state of Kansas through premium pay to these frontline workers. Happy to answer any questions. That is the concept and the idea that we're looking at today. And I appreciate this, that we're taking this into our consideration as a committee.
John, thank you very much. I know a lot of work has gone into this proposal. I'd like to open it up for discussion from the task force members.
I have a couple comments and questions if it's appropriate. So certainly agree with the stated goal. Capacity is clearly the issue. And just a little bit, I think I mentioned it in prior meetings. My daughter's one of those in that front line, right? She's an RN. She's at Heart Hospital. She actually also is a gap filler at HCA Wesley and in these COVID units and working. So that's some context. So I do have some inside knowledge, at least from the cohorts that are around her. I do think capacity seems to be the main issue. I appreciate the statement of that goal. And going on that, I understand we have strings, so I think I'd like to see a discussion around, and maybe we'll do some approval and look at this later. But I understand I want around the reporting and the administration and the processes, and make sure that we're taking into account we're not having counterproductive things happening as well, because this isn't us determining we have this program. This is a request from industry. And so we need to make sure that the dollars, because we're stewards of the people's dollars, that we are putting money into a system that is going to reach the stated goal, that these truly direct capacity. So I want us also to be cautious and maybe have some conversations around things that also may exist in that market that are counterproductive to what we're trying to do. So anyway, I agree with it. I think I would even be prepared to make a motion at the appropriate time, but I'd like to see some discussion with the committee around those things.
Thank you, President Masterson. Other comments, questions from task force members?
Yes, Secretary Tolan, Speaker Reichman.
Yes, Mr. Speaker.
Yeah, I agree with what John and Senate President have stated. One of the things that Mr. Rolfe pointed out, mentioned that there were some guide rails on this money that had to be, not for sure exactly what they were, which is news to us, at least to me. Information we did not receive, because my idea was that we would have this money to be possibly appropriated today, and then maybe in the next weeks come up with the criteria after we have a chance to work with our hospitals to find out exactly what that is, because we wanted to be flexible on how this is. If we think the administrators probably know better than we do on how to retain or achieve our goal of providing as many beds as possible in the state of Kansas during this time. And so I wasn't in favor of a flat rate for everybody, one size fit all. I wanted to see us be a little more flexible. Of course, one of the things that causes a pause is when John mentioned that there's some guardrails on the money that we weren't aware of, which brings to another process question of this whole process and giving information at the last minute on up to a $50 million decision can be frustrating. So I like to see discussion along the lines where we approve up to $50 million in the next couple of weeks, that we come back and figure out what the criteria is when we have a chance to talk to our stakeholders, talk to the hospitals, and see how they would want to use that. And knowing that our ultimate goal is to provide more beds or retain the beds we have for the folks in Kansas that desperately need it. And so we would, at a future date, kind of come up with a plan design. One of the things that I wouldn't want to see is I see this proposal where 5% of this money is going to possibly our consultants and not to our frontline workers. I would think that the Office of Recovery or staff we have at the Capitol could administer that. I hate to see $1 million of this money go out that way, in addition to the the contracts that we already have out there to administer this program, which is a discussion for at least another time, maybe today. And so there's a lot of things I'm saying here, but basically I'm in favor. I think we need to do what we can to help our frontline nurses and our hospitals achieve this goal, especially during this time with the resurgence of the Delta. I'd like to see us be flexible and probably do not have information today, especially with new information just given to us at the beginning of this meeting on the guardrails around this money, that it can't be maybe spent in ways that we thought we could.
Thank you, Mr. Speaker. Mr. Rolfe, could you go back and explain again the guardrails, which I believe come from the Department of the Treasury, and how those apply here, please?
Yeah, and Secretary Burns Wallace may have a clearer picture than me. And the one thing I'd say before I pitch it over to you, Secretary Burns Wallace, would be the proposal here is not a guaranteed $13 an hour that ties the hospital's hands. It's an up to $13 an hour. It's just the top side of that range. So if they wanted to spread it out across more people and do less money, the hospital would have that flexibility, to cover more of that frontline team. But Secretary Burns Wallace, can you help understand the federal guidelines around the money?
Of course, and I think like others have expressed, this is such an important thing for where we are as a state and supporting our frontline workers in healthcare. What I will say is that as this was proposed in terms of trying to create that capacity with those frontline workers, it accesses the part of ARPA that is actually the premium pay component. And so when you activate premium pay from ARPA, that premium pay does have guidelines that are put around it. So what was mentioned by Mr. Rolfe about the up to $13 an hour with the maximum of the $25,000 per person is actually the premium pay guidelines as outlined in the interim final rule for these dollars. And so my understanding with the discussions and with the Kansas Hospital Association identifying that this need to retain staff, this is one of the most direct way, because these dollars all go straight to salary. And when you use the premium pay component, it means that it's a one-to-one in the sense that the way the program moves through, or the program design is that it is salary dollars. And even when we do compliance and reporting, we will have to create a mechanism to ensure that we are identifying that these dollars did go direct to salary in that category of those frontline workers that have been identified. So those guardrails, or just those parameters that were used to try to identify, come with utilizing the ARPA dollars as premium pay as set out by Treasury. So hopefully that gives a little bit of that background.
And if I may, thank you, Secretary Burns Wallace. Lieutenant Governor, may I just add on to that?
Please.
The reason, Mr. Speaker, that didn't disrail the deal was when you look at that amount of money paid over time, it falls within the ranges that seemed reasonable. The thought was we really want to try and help hospitals retain their teams through the end of the year at least. And it'd be nice if it went into next year. And so when you think about being able to give someone, anywhere between $2,000 and $5,000 to stick around, you want to do that over time, right? We didn't want to put a bunch of money out up front and then people could quit the day later, and it wouldn't be, or we'd be faced with trying to claw it back. So something that's on each paycheck every 2 weeks, that's a premium pay on top of your hourly rate, seemed within the goals of retaining folks. And that they need to stick around to get the money, and was within the kind of established ranges.
Okay. Thank you, Mr. Rolfe, Secretary.
Lieutenant Governor Toland, I've got a couple of questions, if I could.
Yes, please, Mr. Pickard.
This Bill Pickard. I guess, first of all, is this kind of a program permitted under the CARES Act? Is there money available under the CARES Act to help fund some of this still? Be my first question. And secondly, it looks like we've got some hospital representatives on the call, and I'd like to get kind of their perspective on really what's going on in the hospital environment and how this specific proposal helps them specifically.
Okay, thank you. Secretary Burns Wallace, can you tackle the first question about CARES Act?
The CARES Act and premium pay was a little bit different. If we can defer to the second half of the question, I can try to run that down quickly. Otherwise, we may have to loop back.
And I believe we have Chad Austin here. Chad, are you on the line?
I am, Lieutenant Governor.
Terrific. Would you like to respond to Mr. Pickett's?
Sure. First of all, I'd like to thank everyone for having this conversation and all the support that's been provided over the course of the last 18 months. I think John summarized it very well in terms of some of the challenges that we're hearing from some of our hospitals across the state, both in some of the urban areas as well as some of the rural areas. As John pointed out, some of the challenges that we're really facing right now are the result of the recent surge in COVID cases, the non-COVID cases that our hospitals are facing, as well as the staffing challenges. And that staffing challenge that we're seeing from across the state really is impacting every hospital that I've been visiting with. And quite candidly, as I visited with many of those hospital leaders, talking with them and talking with their staff as to, their current mindset, it really is kind of delving into a few different reasons why we're facing some of these staffing challenges. From a staffing perspective, I think our hospital workers are emotionally drained over the last 18 months. We went through a period of time where we thought we were getting past much of the COVID-19 pandemic. We thought we saw the light at the end of the tunnel. And this most recent surge has created some PTSD, I would say, for many of our healthcare workers in terms of dealing with the pandemic. And then we've seen some individuals look at retirement or taking breaks from their service because of the challenges that they're facing and looking for a less stressful environment to be able to work in. But we do have with us today as well, and I would welcome the opportunity for him, if he so choose, to allow Kevin Strucker with Ascension Via Christi to be able to provide some on the ground frontline perspectives as to what he's seeing in his hospital as well.
I think maybe you're on mute.
How about now?
Go ahead. Thank you.
Okay. I'm having some audio difficulties, so if you can't hear me, I apologize. I tried to dial in, but maybe this will work. So thanks for the intro, Chad. So my name's Kevin Strecker. I serve as the President and Chief Operating Officer for Ascension Via Christi. The bulk of our health system is located here in Wichita, which is where I'm at, where I'm calling from. And then we have some smaller hospitals around the state in Pittsburgh, Kansas, Manhattan, Kansas, Wamego, Minority, and Salina, Kansas. And we sponsor about 25 critical access hospitals around the state. So depends on how you slice and dice the data, primarily the largest health system here in the state of Kansas. And John and Chad really did a nice job of summarizing our experience. The only thing I would really add, so first of all, John mentioned the burnout. I think Chad described it as PTSD. That is real. The first event, COVID spike that we experienced back in October, November, December was very hard on the staff. I'll tell you, for us here at St. Francis, which is where I'm calling from in Wichita, we have cared for more COVID patients than any other hospital in the state of Kansas. A normal year for us is about 850 deaths in the course of a year from all diseases and injuries. This year, it's been about 1,300 deaths, so around a 35% increase in the amount of death that our staff has witnessed, and that has taken a toll on them. And as a result of that, we did see a pretty sizable exodus of not only nurses, but all disciplines in the hospital, but we'll just talk about nurses today. When you look at our age distribution, so we employ about 3,500 nurses, and we did see kind of a mass exodus into the retirement category. A lot of those, again, when you look at the age distribution, a lot of them baby boomer age, and they themselves maybe had some underlying health conditions that they were concerned about, or had loved ones at home that they did not want to expose them to. So we saw a pretty sizable number of people leave the market, leave the industry. We also had people leave the acute care setting or the hospital setting, and they went to physician offices, ambulatory surgery centers, other outpatient types of roles. And so that was hard for us to get through that first wave. As the second wave started to approach, a lot of our nurses have left to become traveling nurses. And many of them stayed within the state, I think, for quite some time. But as this second surge has hit the southern states much more harder, many have left our state to go to other states to increase their earnings. And so it's a number of things that have exacerbated this problem. John may have the data, but we recently gathered some data from the Kansas Board of Regents. Not only do we have kind of a workforce that was heavily weighted in that baby boomer population that are now retiring or finding other things to do, we have fewer people coming into the pipeline. So the Board of Regents has reported declining enrollment in the College of Health Professions over the last 4 years. And so our pipeline isn't looking very strong at this point in time, which is another problem that we as an industry have to deal with. But I'll stop there and be happy to answer any questions.
Thank you, Kevin. Questions or comments from other members of the group? Yeah, Mr. Rolfe. You're on mute.
Great. I'm asking this question blind here, but it's important for us to understand and for the public to understand that before putting public dollars, that hospitals have been working hard to retain and spending their own resources on this, and it's been my understanding that the expense of traveling nurses, which can be a 4x on what you're paying for your team sometimes, has put a financial burden on many of the hospitals in the state. Do you know, either Chad or Kevin, of work that and I guess processes you've put in place to try and retain workers, or to do this on your own? I know one hospital that spent $13 million on retention bonuses earlier in the year. Just wondering if that's out there. Chad or Kevin wanna?
Yeah, John, I'll kick it off and I'll turn over to Kevin to give maybe some concrete examples as well. But I would say that that's a great question. And one of the things that we have been talking with our hospitals about, and just to confirm with you, is that the hospitals are not waiting for some type of solution only to come from the Spark Committee in terms of focusing on retaining their employees. They're in the process of doing that. They have been doing that throughout this last 18 months, where they're looking at ways that they're providing some premium pay or some type of hazard pay over the course of the last many months. One of the ways that they were able to do that previously, though, is that there were some funds that came to the CARES program directly to hospitals. Much of those dollars, though, have been exhausted from our larger urban hospitals. And for those, any dollars that are remaining for some of the small rural hospitals, they're ineligible to spend those dollars at the current point in time because those dollars had to be spent by the end of June. So quite candidly, we're kind of in this lull where there's a lack of resources to be able to kind of sustain some of those premium pays that we've seen over the course of the last 18 months. But Kevin, I'd turn it over to you to kind of maybe fill in any activities that you're doing from a system perspective.
So Chad, after I spoke, I could not hear any of the follow-up. Cannot hear any of the audio coming to me other than, for some reason, Chad. So I think the question was around premium pay. Is that correct?
Yeah, Kevin, in terms of what is happening from a hospital perspective as to retaining hospital workers over the last 18 months and what hospitals have been doing. And so I shared
Chad,
more.
I'm sorry, I can't even hear you now. So I'm going to dial right back in. I'm going to hang up and dial right back in.
While we're waiting for Kevin to come back in, any other questions or comments related to this point about what hospitals are already doing to address these staffing needs immediately? Chad, did we cover everything that you had to say?
Yes, Lieutenant Governor.
Okay, thank you.
Can I
Lieutenant
ask
Governor.
another question, maybe not necessarily related to what the hospitals are doing, but I had a concern about the level of administrative costs in this proposal. And I was hoping that maybe the Secretary Burns Wallace would kind of help us to understand what's involved. And maybe it's after Kevin speaks, now that he's back.
Yeah, Bill, we'll come right back to that. Kevin, can you hear us okay?
Much better. I must have a much better connection now. I'm very sorry.
No problem. We can hear you just fine. So go ahead. And just to recap, the question from Mr. Rolfe related to what are some of the measures that hospitals have already taken to try to address these staffing needs, the measures they've taken on their own?
Okay, thank you. And again, my sincerest apologies. So some of the things that we've done, first of all, we currently this day right here in this hospital that I'm sitting, we have 140 contract nurses, and we are still running about 100 employees or nurses short. So back to, I think John was talking about our nurse to patient ratios. Those are pretty common across the standard, the 1-to-6 and the 1-to-2 in ICU. So right now we're pushing our staff very hard to take up additional or pick up additional patients, which, you know, is doable for a short period of time. It tires people out, and then the turnover becomes even a bigger problem. And from a quality standpoint, it's not something you want to do long term. So one of the things we're doing is we're just pushing our staff very hard. In addition, the contract labor, we also have offered premium pay. So if somebody works, typically a nurse works 3 shifts per week, 12-hour shifts, so they get in there 36 to 40 hours. So anything above and beyond that, we offer $480 a day to pick up an additional shift. We're doing all kinds of what we call work agreements, which are essentially a retention agreement. So $20,000 over 2 years' time, you get paid out in quarterly installments. We are taking our non-bedside clinicians. So we have over the years a lot of nurses who have stepped into non-clinical roles. They're leading our quality programs, our healthcare information management programs or departments, doing just various non-clinical functions. We've pulled all those people back to the bedside to work as clinicians providing bedside care. So those are just a few things that come to mind.
Okay, thank you very much. Let's go back to Mr. Pickett's question. Secretary Burns Wallace, could you talk about the administrative costs?
Sure, and I have a couple of different answers. So I'll start with Mr. Picker's question, and then I'll work my way. Well, hold on, sorry. I'll start with the question about administrative costs, and then I will actually answer the other technical question that was the question around CARES Act funding. So bear with me. So from an administrative standpoint, I think, you know, and I apologize, I'm looking at the numbers in front of me. I think it was a 4.2 million. That was the estimate, or the 42, sorry. Let me look at the numbers, hold on. The estimate for the administrative costs was, I think, estimated on this project up to $1 million. Not to say that that would be the actual cost or the full cost of what was necessary. This program would be administered one-on-one to the hospitals around the program administration, protocols, distribution, reporting, and compliance. And so standardly, I think when we look at programs, we put a figure on there, but it is not a guaranteed number. It allows us to track the hours of the program. If it comes in less, we wouldn't pay that. If we feel we need to adjust that, I would say, that recommendation can be in there. Understanding though, with every program administration, when we stand up that technical support, we're standing up that support for that entire program administration from the beginning of design all the way through compliance and completion of those programs. This program would be kind of overall housed in KDHE. So understand it's not recovery office staff. It is part of KDHE's overall administration, but there are programmatic aspects that you would stand up that would be unique to this program. So hopefully that gives you a kind of a little bit. And again, it's an up to, it's not, anytime that we put it or try to put the administrative costs in there, we do it in a way in such it's a percentage up to, but we actually can track on the hours that are used and what is used in that program. And then we match that on and we reconcile that with all of the programs. We've done this from the very beginning from CRF all the way through to make sure that we actually have hours that are used for that particular administrative program. So that's that first piece. The other question was the question around utilization of CARES Act or the CRF funds for this. As I was kind of mentioned and wanted to get the details from the team, CRF funds have slightly different restrictions. Remember that ARPA 1 gave this premium pay as an actual allowable option that was pulled out in ARPA and made it a little bit more broader. When we go back to CARES and those CRF dollars, it is a much more tighter COVID nexus. And so by a kind of allowability interpretation, you would almost have to restrict it to those that were solely working directly in a like with COVID patients or in a COVID unit, and it could restrict the way that those dollars could be distributed. Also remember that right now with the state, we only have around about 11 million of those dollars that are unallocated. And so that would not by any means cover the needs that have been identified here. And it would be hard for us to mix those dollars because of the different parameters and criteria around those two spaces of allowability. So hopefully that answered both questions. If not, please let me know.
Yes, thank you. I guess what you're saying is that you'd have to implement full subrecipient monitoring for these funds. You couldn't just, I mean, it's pretty small in terms of what each individual hospital is going to get, but you're going to have stand up some kind of a bureaucratic process to monitor this going forward.
It is, because what I will say is both and CRF and ARPA have two totally different reporting requirements and program design requirements in relationship to how those monies move out into and through. Again, with ARPA, ARPA providing a little bit more flexibility and a little bit more room. CRF and CARES dollars were a lot tighter and how you can move them to and through. So it's just one thing to keep in mind as well.
Thank you.
Mr. Orman, I believe you were trying to get in.
Yeah, thank you, Lieutenant Governor. You know, I've got a question and a comment, and I'm going to ask them together just so that the question has more relevance. But are there other ARPA dollars that we could access as opposed to specifically trying to allocate these from the premium pay component of ARPA that would give the healthcare institutions more flexibility in figuring out how to design their own programs to retain employees? And the reason I ask this question is because, having spoken to a number of the leaders of the hospitals in Kansas yesterday, and having just heard the range of things that Kevin is doing at his hospital to retain employees, it was abundantly clear that they were looking for the flexibility to be innovative. And it's abundantly clear from hearing from Kevin that they actually have done a number of things that are very innovative in terms of how to retain people that might be actually more effective at the ultimate goal of having attended bed capacity in Kansas than simply a premium pay increase. And so that's the basis for the question. is to figure out, are we limited to getting these ARPA dollars specifically and exclusively from that premium pay section that brings with it those attendant guardrails, or do we have general ability to support the healthcare system in Kansas and then allow them to use the dollars to retain employees in the most effective way they can determine?
Thank you, Mr. Orman. Secretary Burns-Wallace, can you take that question?
I think my the short answer is that these are the most flexible dollars. The other healthcare related dollars that come in are tied to other specific initiatives or program. That's what the it makes it, they're tied to things like testing or vaccines and are a lot more restrictive because they came in tied to specific other areas or initiatives. And so when looking at dollars that were available, and please understand that this is that across this, I think the work that is trying to be done is if we could find other pots or other ways. I think as was mentioned by Mr. Roth, the spaces and places of that support for traveling nurses and in those spaces, there's potential to be able to leverage into FEMA dollars. So we've already identified some other buckets that can help with some other of the ideas or initiatives that are being used. And this one allows for that premium play. From I think the perspective of looking at being able to stand something up, get something out the door that the industry believes will be helpful and effective quickly for them to be able to leverage into. This was the best and the strongest and most flexible set of dollars to leverage into.
Thanks. And again, I'm looking at this also from a perspective of someone who's been, working with a half a dozen businesses trying to address various labor shortages as well. And I will tell you that ultimately, as we look at it, premium pay is not the only lever that can be pulled. In fact, we generally try to shy away from that because there's, as you know, wage price inflexibility. And when you raise someone's base pay, it's awfully hard to ultimately change that if you get into an environment with different conditions. And given that healthcare is the second largest expenditure on Kansas's state budget, I would hate to be encouraging a program that ultimately leads to structural inflation and future costs to the state of Kansas as we're trying to meet healthcare needs in 2022 and beyond. And so my counsel would be, to the extent that we can, and given what Speaker Reichman said about these guardrails being something that we're being made aware of right now, to the extent that we can, I would actually recommend that we spend a little bit of time, not much, because I recognize the urgency of the need and the work that the hospitals are already doing today, but not much to sort of dig into this and make sure that this is really the only approach we can take. Because ultimately, I would far prefer to allocate up to $50 million to the hospitals and then allow them some flexibility in terms of how they use those dollars to retain staff and again, get us to the point where we have appropriately staffed hospital beds throughout the state.
Thank you, Mr. Orman. Other comments or questions from the task force members?
Probably got my question quota met here, but I guess I do have a question about for Kevin. Licensed bed, as we've already talked about, is an imperfect denominator in terms of trying to determine what each hospital should get, because I have the impression that some hospitals operate much closer to their licensed beds than others do, and I would assume that given the mechanics of this calculation that some hospitals are going to have a lot more money to throw at individual employees than others, just by virtue of the fact that they're operating much below their licensed bed capacity. And do you have any concerns about any kind of piracy occurring between hospitals in Kansas? And what restrictions do you think we need to put on this money in terms of spending it for recruiting from other hospitals in the state?
You know, this is an area that I might defer to Chad and KHA because I don't know what the perfect way to allocate this money is. And I'd hate to give you ideas that are sort of self-serving. You know, we've kind of deferred to KHA to come up with a recommendation that they see as fair to all the hospitals, both in the suburban or urban areas and rural areas. What Senator Orman was talking about, I think is a great recommendation if there is some latitude. You know, in most of the markets that we serve, so again, in Wichita, Kansas here, I think we're the third or fourth largest employer. In Manhattan and Pittsburgh, we're second largest employer behind the universities. And then as we get into the small critical access hospitals, many of those are the largest employers. So, you know, I applaud you all for thinking through how you can help us retain and attract talent. To Senator Orman's comments, you know, we're trying to think of how we bring net new nurses to Kansas. So whether it's sign-on bonuses or loan forgiveness, relocation expenses paid for, those are things that we're toying with to try to figure out how we bring talent to the state of Kansas versus just, you know, shuffling the same people around. And, you know, last thing we want to do is drive up wage inflation to an unsustainable rate, as Senator Orman was talking about. So, you know, I guess I would say we've kind of deferred to Kansas Hospital Association to put forth a recommendation that is fair to all the parties, and I think at this point they've determined that the licensed bed was the best option.
Thanks, Kevin. I might just weigh in for a second. And Bill, that's a question that we struggled with as we were looking at what's the best way of doing this. And we have looked at some other states that have moved forward with similar proposals, including in Arkansas, and they did use the licensed bed component for that. We did look at other ways to be able to allocate those funds, whether it's staff beds, whether it's staffing, et cetera. But those numbers change just on a regular basis that it would be hard to be able to kind of pinpoint at one given point in time. And I know the licensed beds from our perspective is something that is something that's already known. It's something that has already been submitted. We believe it's something that, you know, you can tie back to much more easily as we're looking at a fair way to allocate some of those dollars.
Chad, I've only got anecdotal evidence of this from having traveled the state and talked to a number of hospitals, but would using licensed beds tend to favor critical access hospitals in large part because I know many of them are operating with censuses that are well under the licensed bed, whereas more of the urban hospitals historically have operated much closer in terms of their daily census relative to their licensed beds. Or and again, my evidence is only anecdotal, so it's a genuine question.
Yeah, no, and that's a great question. I think there's a couple things to kind of keep in mind related to the proposal that I believe John talked about. One is kind of tying it with the staffing somehow with the licensed beds, but also recognizing the ICU component as well and the ICU nurses. So I think that does level it out slightly. I would say that when we look at our critical access hospitals, you know, many of them can only be licensed up to 25 beds. Many of them are licensed at 25 beds, and their staffing probably ranges from maybe 7 to 10 all the way up to 20 or 22. So I think, you know, they're probably, you know, maybe in some cases you might see some that are a little bit further away from their licensed bed than others. But I think the same is true with some of our urban hospitals or PPS hospitals that are located with throughout the state as well.
Thanks,
Can I
Chad.
have to ask a specific question related to that? I mean, to like Kevin, how your system, where do you operate in as far as your licensed bed compared to your general, you know, kind of your average census?
So I'll give you an example. I'm sitting here at St. Francis today, which if you're familiar with Wichita, that's our large tertiary hospital. This is where patients come from across the state. We're licensed, I think, for around 800 patients. We operate an average daily census of about 400. Now, having said that, we also sublease some of our licensed beds to another hospital called Select Specialty. It's a long-term acute care hospital. So think of it as a hospital within a hospital. We also lease 12 of our beds to Harry Hines Hospice. So again, kind of a hospital within a hospital. So all kinds of caveats, but to answer your question, President Masterson, probably about 400 on a licensed bed of 600.
Thank you,
That
Kevin.
we're-
That
we
actually brings
ourselves
up,
are using.
who would get
Sorry.
in this proposal, who would get the dollars for the licensed beds that are leased out, if you will, just out of curiosity?
I cannot answer that question. I'm unsure about that.
Yeah, that's probably one that's more directed at me. It's a great question. So the key here was we were trying to figure out a way to allocate funds, because this whole conversation around flexibility has been like forefront, and this is some, I think about our restaurants. There's places where we're struggling to hire cooks, and there's places where we're struggling to hire servers, and you may need to focus on one area or another. One place it might be ICU nurses, another place it might be respiratory therapists or something else. And hospitals need that flexibility to focus on where they need to retain to ensure we've got the capacity that we need. And so the idea is, how do you get this sized right, essentially, for the amount of dollars that can go to that hospital that they can push into payroll and no other area, right? That's the accountability measure, is that you can look at payroll, not be used to create appreciated Bill's question about piracy or stealing from each other. We don't want to create a bidding war in the state against each other and make our problem worse. So licensed beds was the thought to be probably the best denominator, most consistent denominator that would help catch the size of the hospitals that we're dealing with, and the breakdown between inpatient and ICU. So it's not that there's a dollar amount that goes per bed, but it gave us an idea of the number of nurses and frontline workers that they had, that then they could take that money and figure out who to push those payroll dollars to retain, if that makes
I
sense.
think that's what I'm asking in Kevin's unique situation, where he has beds he's got leased out. Are those his beds and he's getting the pot, or the people that are managing his beds in his facility getting the pot to be creative with their personnel?
That would not, well, I mean, Chad may be able to answer this more completely. The thought wouldn't be that money would pass through to the hospital, inside the hospital, because they wouldn't be operating the ED or doing that work. But Chad, am I understanding that correct?
Well, I think, I'd have to learn a little bit more about Kevin's situation that they have at Ascension, but I would say that from our perspective, really that calculation or the allocation was really to try to get a number for hospitals to be able to identify, what that allocation would be for their given facility. And then, as John mentioned, to have some flexibility to allow the hospitals to be able to use those funds the best that they can to retain those high demand workers. So in some cases, it could be nurses, in other cases, it could be respiratory therapists, whatever the case may be. But I do think, Senator Masterson, it's probably the same nuance that we have with, is the licensed bed or staff beds, or whether we're talking about number of staff. It's all a little squishy, and it's the best information and data that we have available. I would anticipate that if Via Christi is licensed for all those beds, or any hospital that's licensed for those beds, that's the approach that we've taken thus far, is that would be how the allocation would be made.
I don't think I necessarily have an issue with that. I think it goes to the point of, we probably need to test some of these guardrails. I think Greg was spot on that there's some probably innovative things outside of what appears to be a guardrail that might be a better way to retain. Because obviously we are looking at what we are wanting with these dollars. We want healthy frontline workers attending beds, right? So whether that's retaining or adding our capacity, that is the ultimate goal. So that's where I want to make sure we're adding not just flexibility, but protecting the downside. So I think, just to get us moving along, because I understand we have urgency with these, but I think we do need to have some type of follow-up around our testing of these guardrails and really how strong or where they're at, along with looking at other ways we can handle it. Some of the reporting and administration, because this is a 4-month deal, right? The way this is proposed, it starts the day before yesterday and goes to December 31st, right? So this is a 4-month, time sensitive, but we do need to have a better understanding. But with that, I would actually, to get the ball rolling, I would make a motion that we approve this request with a couple caveats, that we will reconvene around some of what these guardrails are and parameters are. And that also, I would like to see, this motion is also going to contain that facilities would only be eligible for these dollars if they're not instituting counterproductive policies and mandates that also make it harder to staff these beds. And we can have, that can also be part of how, as we test guardrails and look at some of these things. So I think boiling down the motion would be that we approve the request, and then it's subject to the follow-up on the guardrails parameters and the eligibility requirement. There be no counterproductive policies or mandates implemented that are counterproductive to what we're trying to accomplish. And I would make that as a motion for discussion.
So, President Masterson, just so I'm clear, what we're proposing is to allocate $50 million or up to $50 million, subject to finalizing program design, with a focus on guardrails and counterproductive behavior, is what you're saying. Okay.
Yeah, that's exactly what I'm saying. And that would also be time sensitive, because the reason I'm making it in this fashion, we have State Finance Council later this afternoon. The dollars could be allocated to this pot and approved. But I think it'd be imperative that we, within the next week or so, tighten some of that down with some of our actions. So that's why I make the motion in that fashion.
And could we set a specific date, just so the hospital association and the hospital some certainty that we plan to get it done by a specific date, like September 15th, September 13th, something like that?
Yeah, that could either be included in the motion, and I could amend the motion to give a date, or we could have the chairman basically discuss what dates he might be able to call another meeting next week.
So President Masterson, I do intend for the Spark Committee to meet next week. We need to continue the work of this group and certainly come back to your points. So we will work on getting that scheduled. But I do want to make sure I've got clarity around, I guess, the question of, under your motion, are the funds accessible to the hospitals that need these dollars now, or will that be pending until this later discussion that will happen next week?
I think the way I stated the motion, they would be subject to that. Now, I'm not sure when, so if we're starting to pay these nurses day before yesterday, when that hits the payroll, right? So the way payroll is, those are actually, dollars aren't going to be expended until that payroll set comes out. So I believe we would have, and if we're having a meeting next week, that would certainly be plenty of time to make sure it doesn't impede the dollars that are starting to pay nurses the day before yesterday. And
Lieutenant Governor Tolan, if I can jump in, and that's correct. The reality of it is that it's going to be probably about a 2021 day delay for it to go out. The reason you set the date for September 1, though, is once it's approved, it will allow the hospitals to be able to go all the way back to September 1 to grab any adjustments and then to take it forward. So as long as, yes, if we can get the rest of these pieces nailed down and figured out, within the next 7 to 10 days, it actually shouldn't delay the distribution from moving through, because it was already going to be probably about a 21 day to be able to get it stood up and to transfer dollars out, if that helps. And just as I'm speaking, I would say that I would, if you are ready to accept the motion, that I would be interested in seconding it.
Thank you, Madam Secretary, because and this is not uncommon for those that aren't in the legislative process generally, that we'll allocate the dollars and get them set aside, and then you kind of have these rules and regulations that follow up. So that's the vein in which I make it, and thank you for the second, Madam Secretary.
All right, great. We have a Motion and a second. Further discussion on the motion? Mr. Ross?
I might just make the
Oh,
point. So am I okay?
Yeah, go ahead, John.
Okay. You on the September 1st, I mean, that would be a backdate opportunity on pay essentially. And if we're giving hospitals flexibility, they may decide they don't want to start it till October 1st, or, something like that. So I just want to make sure that that's said, as far as people being able to set up expectations for team members and their hospitals, that there's us setting aside this money doesn't mean that they can expect that September 1st they'll start getting more money. It's just we're setting aside that money with the sense that it could be backdated to that possibly, depending on how that hospital strategy on helping us keep and expand capacity would go. That'd be right? Just want to make sure we're all on the same page. Okay.
I only used the date because that's what was in the proposal.
Yeah, I knew. Yeah, I just wanted to make sure the expectation. I think we all understood that. I just want to make sure anybody watching today is on the same page with us. Thank you, Senate President.
Thank you, Mr. Rolfe. Speaker Reichman.
Thank you, Secretary Tolan. Yeah, I just want to lend my support to this. Like I said, up to $50 million, and to give us a chance to work with our hospitals to see what's most flexible. I'd also like to see if there's ways we can have the locals participate in this. They've also received a lot of federal money. This would be a great place to stretch these dollars so that actually it can possibly be more than the 50 million. I also have a lot of concerns, kind of along the conversation that Bill Pickard talked about, a 5% charge for administration on these. I think a lot of money we've allocated to the recovery office, it would seem like this is the reason we would allocate those types of funds there, or to our consultants. I wouldn't hate to see $1 million of this or 5% of this go to more fees that aren't needed. And so as we develop the conversations over the next couple of days or weeks on this, I'd like to see us continue to have the most flexibility as possible. Hopefully find a way that locals can participate, that we can stretch this to be even more. And again, with the goal in mind that we're going to get more beds staffed, or at least retain the ones that we have. So I'm supportive of this. I did want to talk about some of the things, we're talking about, up to $50 million for our frontline workers. There's another group of workers out there, our home and community-based service providers. I understand there's been about a 10% bump, almost $80 million back in April that was given to these providers as well. And so far that hasn't been given to these providers. Is there any way we can get an update, and maybe not involved in this motion, obviously, but before we get off this call, I'd like to some type of a update. Again, as we're looking at helping our frontline workers, again, we have the folks at the home and community-based services that money's already been allocated, federal funds that haven't gotten to those providers yet. And so we'd love to have at least a discussion, or at least a plan for the follow-up on that, which again, kind of highlights kind of the discussion we're having on why we need legislation approval or oversight in federal funds. Again, this money was appropriated back in April and has not reached the folks that need it the most yet.
Thank you, Speaker Reichman. On your question about home and community-based providers, I don't know that we're prepared today with the details on that. However, when we meet next week, I ask the Recovery Office to have a full report for us on that, and to have someone present who can answer detailed questions. That's great. As long as we're talking about frontline workers and trying to help them, I wanted to also bring that up. So appreciate and look forward to the update. Great. Thank you very much. Other discussion? John, Mr. Rolfe?
Yeah, I'd just like to thank the committee for entertaining this, and I love the way we think. I love the way we come together, and I just continue to look forward to how we as a group are going to be able to help impact the state. And I just appreciate the shared sense of urgency around this. So I just want to thank you all for the discussion. Great questions, and we're better because of it. So thank you.
Well, I'd echo those thanks, and also thank you, John, for your work in developing this proposal. This has been a very good, thoughtful conversation with good questions from all the members. And so grateful for that. I'm also grateful for our hospital partners. Chad, Kevin, thank you for being here today and for your work to fashion this proposal. But we have a motion and a second. Without further discussion, all in favor, please say aye.
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 All opposed? Motion carries. Thank you very much.
Hey, Mr. Secretary,
Yes, Mr. President.
one thing I wanted to have a brief conversation around structure. I know that's, you did not have it listed on the agenda, but, you know, being under Robert's rules, I'd like to have I'm actually prepared to make a motion on some structure around the proposal with Greg, that Greg made, but I understand there's some conversations that are going around that might be productive and it may not be necessary now. Do you have a date? I mean, what I'd like to make sure is we do have a little discussion around that, a date and time in which we can anticipate putting our structure together.
Mr. President, thank you. I want to have that conversation too, and we will have that conversation next week. I don't have a date right now. However, I will ask the recovery office to reach out to all members today to check calendars. I want to make sure we can have full attendance. I know we have very busy people on this task force. And so we will make that contact this afternoon and find a date and time that works for everyone. And we will include the conversation about structure. We will have the follow-up on home and community-based providers and address the other points that were made today that we need to follow up on. So
Very
maybe
good.
a long meeting, but it'll be an important and a good meeting. So will that work, Mr. President?
Yeah, that'll work. Thank you.
Thank you very much. Okay. Well, without further discussion, I will ask for a motion to adjourn.
So moved.
Second.
All right. Motion is second. All in favor, say aye.
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 Opposed? All right. Thanks, everybody. We will see you next week. Have a good day.